Good afternoon. My name is Philip Pirie. I am a father bereaved by suicide and a suicide prevention campaigner. Suicide is the worst possible outcome of poor mental health. There are 3 times more men than women who die by suicide, and suicide is the largest killer of young men. I'm going to present my case for a public health campaign for the reduction of the stigma of suicide. But first of all, I want to talk about Tom. Tom had a very happy childhood. My mother used to say, "There are so many people who love Tom," and she was right. Tom had loads of friends. He did well at school and university. He could speak 3 languages fluently. He loved sport, especially football. And he wanted to be a teacher because he wanted to do some good in the world. Tom took his own life in July 2020, the day after he'd been assessed as low risk of suicide. I thought at first that Tom was one of the unlucky ones, one of the few who'd been wrongly assessed as low risk. But I was utterly shocked to discover that Tom was not the exception to the rule. He was the rule. Of the 17 people who take their own lives every day in the UK, 5 of them are in contact with mental health services, and 4 of those 5, that is 80%, are assessed as low or no risk of suicide at their last contact. These are the latest comparable data. The 4 of the 5, the 80%, has been called the low-risk paradox. I felt very angry when I found out that the low-risk paradox had been known about for over 25 years and so little had been done about it. But I didn't want to stand on the touchline criticizing the players on the field. I wanted to see if I could up my game, maybe get on the team, and even help score some goals. I'm very grateful to Professor Lewis Appleby and others who helped me along the way, and I'm particularly grateful to Dr. Adrian Whittington, who made me his co-chair of the team that wrote the new NHS England guidance, Staying Safe from Suicide. This was published in April last year. That guidance applies to all mental health practitioners in the UK, be they in the NHS, the private sector, or the charity sector. Tom was one of the 4. He did seek professional help. But the approach taken by Tom's counsellor was wrong. Professor Iqbal has shown us very convincingly why it is unacceptable to try to predict and stratify suicide risk. Suicidal thoughts are very, very changeable, even in the very short term. The guidance says do not try to predict and stratify suicide risk, but take a person-centered, collaborative approach to the patient. Practice is changing, but there is still a very long way to go. I want to talk about the difference between the 17 and the 5, the silent 12 who do not seek help. Stigma is one of the main reasons why these silent 12 do not seek help. and every speaker before me today has referred to stigma. That is why I am campaigning for the government to undertake a public health media campaign for the reduction of suicide. Stigma acts on both sides, those feeling suicidal and the rest of us who are afraid to ask if people we're concerned about, if they're feeling suicidal, for fear of putting the idea into their minds. It does not put the idea into their minds. This leads far too often to the stigma trap. He is thinking, I'm too ashamed to tell her I'm feeling suicidal. And she is thinking, I'd better not ask him if he's feeling suicidal, as it might put the idea into his mind. We know now that asking people if they're feeling suicidal does not put the idea into their minds. On the contrary, many are relieved that someone has connected with them and named their darkest thought. Public health campaigns work. I'm going to pick up the example of HIV/AIDS, which Professor Iqbal has spoken about so eloquently already. At its peak in 1984, 1,750 people died from AIDS. That is a quarter of annual suicides today. Now, thanks as well to medical treatments, there are about 200 deaths a year from AIDS. AIDS had a strong stigma attached to it, as has suicide today. And as a recent Scottish Government campaign has put it, adding to what Professor Iqbal has already told us, stigma is more harmful than HIV. The Men's Health Strategy was published by Wes Streeting, the Health Secretary, in November last year. It quotes drink driving campaigns as examples of how to change social attitudes. It is time now for a change in social attitudes to suicide. My MP, Sarah Olney, has been an indomitable supporter for many years, for which I'm extremely grateful. She and I had a meeting 2 weeks ago with Baroness Merron, Minister for Mental Health, who opened the conference for us this morning, and Sarah and I put to her the case for a public health campaign. The Minister has been active in helping to implement the guidance staying safe from suicide, and we are very grateful to her for that. But let me repeat, there is still a long way to go, as a large majority of organizations are yet to implement the guidance. Sarah Olney asked Wes Streeting in the House of Commons on the 25th of November for a campaign to reduce the stigma of suicide. Wes Streeting replied that he was absolutely confident that we can reduce the terrible stigma of suicide. I am asking for action to back up those words. There is an overwhelmingly strong moral argument for such a campaign. Stigma of suicide is real, it kills, and it can be reduced. Suicide is unarguably a public health issue with over 7,000 suicides a year. But on top of that, according to an NHS morbidity survey published last year, 1 in 13 of us will attempt suicide in our lifetime, and 1 in 4 of us will have suicidal thoughts. So of the 150 people or so in this room, getting on for 40 of us, will have had or will have suicidal thoughts in our lifetime. A large majority of those who die by suicide every day, that's the 12 of 17, are not in contact with mental health services. Stigma stops them, and we can stop stigma. I want to make an important point. If all those who are not in contact with mental health services, the 12 of the 17, suddenly turn up asking for treatment, services will be overwhelmed. Yes, we need to provide more resources, but what would happen in practice is this. Many of the 12 would engage with family, friends, or others and not need to go to services. In addition to the moral argument for a public health campaign, there is also an overwhelmingly strong economic argument. Each suicide costs the country £1.4 million, at least £1.4 million, using methodology adopted by NICE, the National Institute for Health and Care Excellence, and government departments such as the Department of Transport when calculating the benefit of road improvements. I'm very pleased that David McDade, who derived the 1.44 million figure for the Samaritans, is with us today. So annual suicides of over 7,000 cost the country £10 billion a year. Let us say that a public health campaign costs £50 million. Only 36 lives have to be saved to cover that cost. If the campaign were a new medication, NICE would approve it like a shot. I now want to compare suicides with total road deaths, not just drink driving, but all road deaths. These data are from the Office of National Statistics for suicides and from the Department of Transport for road deaths, expressed as a rate per 100,000 population. In 1980, the left-hand end of the graph, the rate of road deaths, that's the orange line, was about 11 per 100,000. The suicide rate, the blue line above it, was about 15 per 100,000, approximately 40% higher than road deaths, but fairly close. Now, look at what happened since then. The rate of road deaths has declined consistently to 2024 to just over 2. That's the right-hand end of the graph. The suicide rate, however, having declined to about 9 in 2006, where I put the vertical line, then began to rise to about 11 in 2024. So by 2024, the suicide rate was 4 times the rate of road deaths. In the last 44 years, the gap between suicides and road deaths has widened dramatically, from about 40% higher to about 300% higher. Suicide is therefore not just an outlier compared to fatal medical conditions, it is also an outlier compared to fatal non-medical conditions. While nearly all mortality rates for major causes of death, including road death, have got better, suicide rates are not getting better. They are getting worse. I hope I've been able to convince you that there is not only an overwhelming moral argument, but also an overwhelming economic one for this public health campaign. If I've convinced you or you didn't need convincing, please do what you can to support it. Every voice counts, especially the voices in this room. Please do what you can to get your organizations to support it, and please write to your MP. If you have any questions, comments, or want to help, please speak to me this afternoon or get in touch by email. My email address is mail@philippirie.com and is on the screen now. Over 38,000 people have died by suicide since Tom died in 2020. That is equivalent to a stadium's attendance at a Premier League football match. If those were road deaths, something would have been done about it years ago. But we have been far too silent for far too long about suicide and the stigma that stops us talking about it. Politicians and policymakers are not immune to stigma either. It infects them too. It stops them talking about suicide. Things have to change. We need to act now. Two weeks ago today would have been Tom's 32nd birthday. A group of Tom's friends play a memorial football match for him every summer. And last year, some wives and babies came along too. I can't help thinking what could have been. I want something good to come out of Tom's death. I don't want other families and friends to go through what we've been through. A public health campaign will reduce suicide. It will avoid the unbearable mental torment of those who take their own lives and the indescribable grief of the bereaved. People will engage confidently with those having suicidal thoughts. And above all, those suffering from suicidal thoughts will know that by naming them, they can tame them. Thank you.